Copyright Stanford University, all rights reserved.
Thank you very much. So the title that I thought might be of value to this group, and certainly has been to even our residents, has been the whole issue of HPV management, because we see a number of these cases come through our multidisciplinary clinic. And so what I thought I'd do is spend the better part of the next hour reviewing these main issues. I wanted to actually take a bit of a historical perspective, partly because since going to Hopkins, I've had reason to walk the hallways and to appreciate that giants such as Osler, Halsted walked these same hallways, and more significantly, Osler was Canadian, spent time at Penn, and then went to Hopkins. And so, not to draw any analogies, I feel honored that he actually followed the path. What I couldn't find out was whether or not he actually made his way down to Florida, which my wife jokes that that's probably where we're going to end up with the current course that I'm traveling. And then I want to review the second point about risk factors for complications. In fact, I think this is probably the most important aspect of this presentation. Transoral surgery is not a panacea for everything, but if I can effect some knowledge to understand what is it that we're, in our treatment approach is causing swollen problems, so that we can have a much more rational discussion and development of future strategies to minimize this as a problem, particularly in the HPV patient, then this trip was worthwhile. And lastly, I want to show you what national and also local efforts are being done in terms of developing new strategies based upon some of these principles that are already existing in the literature. And by way of disclosure, Intuitive Surgical has been kind to provide travel expenses, but by no means has the content of this lecture or anyone in the past been influenced by them. I'm also a consultant for Pinnacle Biologics in that I also do PDT, photodynamic therapy in the head and neck, and I'm involved with the development of what hopes to be a national trial for PDT for the larynx, not for laryngitis, unfortunately. This is William Halsted. It's interesting that I would go so far as to say that the foundation for why we all practice surgery, including head and neck surgery, probably has its roots based upon the fact that this man was a lifelong cocaine addict, believe it or not. And we would not be doing what we're doing right now if it wasn't for the fact that this man became a cocaine addict. So the story goes is that Halsted was practicing in New York, very flamboyant, very well-known surgeon at that time, and known for his speed and technical excellence. And he actually practiced at Roosevelt Hospital on the West Side. It became past that at that time, surgery, as many in the audience and I already better than I do, that surgery in the late 1800s was really regarded with disrepute. It was really more an assault on the patient, because why? Patients didn't live, and it was basically a bloody operation. There was no anesthesia. There's no way to control hemostasis, and infection ran amok afterwards. And what happened was that Halsted intrinsically was very inquisitive, and he made the observation that cocaine had a topical anesthetic property. And so what he started to do was self-inject. And with his residents, they also started to inject each other. And unfortunately, at that time, it was not known, obviously, of the addictive potential, and he became addicted. And soon thereafter, he lost his position at Roosevelt Hospital. And his good friend, William Welsh, who was the first recruit at Hopkins, really? Saw fit to recruit Halsted in 1896. And gave him a research position. And it allowed Halsted, as history tells it, to effect some ability to hide his cocaine addiction. Being primarily a researcher and spending time in the lab, his whole approach basically changed when it came to surgery. And he no longer was this flamboyant surgeon, was very methodical. In fact, actually, a lot of historians criticize that he took too much time to operate. He felt the tissue, examined the tissues that the knife was cutting. And it is with this approach that led him to make a number of advances in both surgery, both in terms of septic techniques, but also in terms of techniques in operation. I mean, he's known for a number, thyroid and the gallbladder for some developments, but perhaps the biggest influence is actually the Halsted Mastectomy. We all know this, and the concept here has had significant influence in different surgical techniques. And the concept was that he observed that women presented with large masses and lymph nodes, and it was his premise that you needed to remove everything en bloc in order to effect cure. In fact, actually, he presented data, obviously, that actually demonstrated that you can actually cure this, and that was hailed with great adulation and actually put Hopkins on the map for that reason. And he had a big influence on George Krill, and obviously everyone here knows who he is better than I do. But I thought it was interesting because I wondered why head and neck surgery was the way it was. And in fact, if you look back, Krill was significantly influenced by this idea of en bloc surgical resection. And Bobby Alford writes about this in JAMA. And he writes basically showing that actually Krill demonstrated in this paper, this was his landmark 1906 paper, that basically said that if you did en bloc surgical resection, you could actually cure head and neck cancer. And that, again, was the first time. And at that time, a lot of the data, if you go back and read the literature, is largely prose. And here it says, I would direct special attention to those 48 trace cases that had a radical block dissection, 9 of which are living. Amongst the 12 trace that had a block dissection, 3 years living, 9 or with 3 years follow-up, 9 are living. The idea that if you're going to cure head and neck cancer, you have to remove everything en bloc, and that meant even including the removal of their intervening lymphatics. And so this notion that you had to remove everything on whole, I think still permeates in our thought process. And I wanted to understand that because I think it helps put in perspective a little bit about where we see transoral surgery. Similar to radiation also went through a bit of evolution. It went from spot field radiation, where Gilbert Fletcher demonstrated that prophylactic radiation and still spot welding in this paper was better than if you actually gave the radiation at the time of the recurrence. And this is the paper that showed that whole neck radiation was better than spot welding here, and that actually the dose of radiation that you gave was very important. And then the area that got treated and the dose that got treated further increased when he demonstrated that if you're going to electively treat head and neck cancer, you had to give enough dose of radiation, and the recommendation that fell out was typically about 5,000 centigrade. And so what we had was going into the 70s and 80s was big surgery, big radiation, bilateral neck. And I remember as a medical student seeing going up and seeing basically was then referred to as a commando procedure, the neck skeletonized and then put back together, and then patients getting radiation. And we gave radiation through everything. And if you had even a lateralized lesion on the tongue base, you gave radiation right throughout. And we basically accepted that as the de facto standard. And we even gave radiation to patients who actually didn't even have pathologic evidence of risk for cancer coming back, as evidenced by this very seminal paper in the radiation literature by Lester Peters that really helped to define the doses of radiation we're now using, which we started using when we were developing transoral surgery at Penn. That is doses on the range of 57.6 through to 63 grade, really, because although the randomization in the patients who had high risk pathologic risk factors to 68 was also to 68 grade, there was no difference in terms of local regional control. And I just bring this up because I'll refer back to this at a later slide. And it wasn't until the early 2000s when Kian Ang did a follow-up trial to that dose escalation post-op trial that we started to see patients actually not get postoperative radiation. And these low-risk patients were the T1s, T2s, N0, N1, negative margin, no other adverse pathologic risk factors, no extracapsular extension, and demonstrating that actually for the first time that you did very well. The local regional control here was 90%, but more interestingly, as proof that radiation actually works in the postoperative setting, the intermediate risk group that actually had risk factors that got 57.6 gray actually did comparable to the low risk group. And this was and so what it tells you is that there's a certain level of inherent risk when we recommend observation, mainly probably because pathology is not identifying high risk factors or because the surgery didn't completely remove everything, even though it was sort of this big surgery. And so historically, there was a lot of development, and this institution has a lot of involvement in the development of non-surgical management, mainly because this question started to be asked. We started to question about the functional impact of these big-time surgeries and saying, was it really appropriate to do so? And along came basically 30 years of work summarized in this slide that in essence have demonstrated that if you change how the radiation is scheduled, or what we aptly refer to in our field as altered fractionation, that is, if you give the radiation twice a day or 3 times a day based upon certain radiobiologic principles, for instance, what we call accelerated is the notion of you wanting to give radiation a shorter period of time such that any tumor response, proliferative tumor response, could be minimized and therefore you improve your local regional control. Or this concept of hyperfractionation whereby you give higher total doses of radiation without causing more normal tissue complication, because what you do is you dial down the daily fraction size of the radiotherapy because the risk of complicating or injuring the mandible and neurotissues is related to the daily dosage you give, but give it twice a day so that you can still maintain sort of what we call sort of treatment efficacy. What we see in a number of meta-analyses that have been updated by Jean Borges is basically these schedules do in fact actually improve local regional control. Along that line, around the similar period of time over the last 20, 30 years, a lot of investigators started investigating this concept of radiosensitization with drugs, particularly giving it concurrently with radiotherapy. As you can see from there, both have demonstrated survival benefits. And then along comes the whole issue of cetuximab that was updated recently, showing continued survival improvement based upon this idea that potentially we could develop agents that could specifically target tumors. And I put this up to be a little bit provocative also, because there has been a general assumption that because of Table 1 in the original publication, New England Journal, that said that the rate of acute mucositis was the same in both the radiotherapy and cetuximab, that this drug is specifically targeting tumor tissues and not normal tissues. We really don't know whether that is true. In fact, actually, there's never been some long-term follow-up reporting of late toxicities or even swallowing complications from this. And frankly, we don't know whether or not that actually does support that. RTOG, interestingly, is doing a very interesting trial, RTOG 1016, that will give us some insight because it is randomizing patients with HPV-positive disease to radiotherapy versus radiotherapy and cetuximab. And as a secondary endpoint, late complications will actually be evaluated, and we'll be able to have some insight whether or not this actually is the case here. And then if altered fractionation is good, concurrent chemotherapy is good, and cetuximab is good, then all three has got to be good, right? So that's actually what RTOG 0522 studied, and this was the study design. There was a fairly straightforward randomization whereby the experimental variable was actually cetuximab, and basically it was a negative trial. And when you break it down by P16 status, while there's some suggestion of some benefit in the P16 positive group, the hazard ratio crossed 1, and one really can't make any definitive conclusions in this regard. And so we're left with, in the modern era where we know that HPV-positive disease is increasing in our patients, we have to ask what really is the optimal management for this. And I would submit to this group that we really don't know what the optimal management is, partly because of this. there continues to be concern that the treatments that we're doing right now with the bevy of treatment options that I've just shown you runs the risk of injuring the swallowing in our patients. And this is perhaps the most gross example. It was a patient I treated when I first arrived at Penn many years ago. You know, he had a right lateral tonsil that extended down below the pharyngoepiglotic foot, was really on the lateral wall a little bit. And as a result of the fact that we had non-conformal treatment and we gave him chemoradiation, I treated both sides, and as a result, his entire laryngopharynx got the same high dose. So this area here where you really want to put the dose, this area got the same dose as this area here, unfortunately. And you can see the late effects. The epiglottis is edematous. There's very ineffective laryngeal elevation. There's interarytenoid aspiration. There's circumferential fibrosis in the pharynx there. Here's the other reason why. The trials that were done in the last 30 years actually lumped everybody together, stage 3 and stage 4. And we had to do so because we needed the patient numbers in order to be able to power the studies. And while that was important, what it did was it actually created a dilemma. In the yellow here is actually stage 3 and stage 4. And the problem is that we all recognize that we're probably overtreating some patients, like the N1 disease that I've highlighted in red with chemoradiation, even to the point that the NCCN guidelines, if you actually look for the N1 disease for oropharynx, even recommend that radiotherapy may be appropriate. And there really, to some degree, is there's less high quality evidence to support that position. It's just the fact that we don't really know which patients really benefit from concurrent chemotherapy to justify the risk at this point. But I would submit to this group also that we have to figure this out. Why? Because while Marcy List did some really great work in the 1990s from the University of Chicago showing that intensification of the treatment, patients kind of got used to it in terms of their quality of life. They're kind of basically saying that you can intensify, you can cause a lot of toxicity, but the quality of life dips down at the end of the treatment by a year or two. It kind of comes back up because patients are robust and they kind of adjust to everything. And that was sort of perceived as a way or justification to continue the efforts to intensify treatment. The problem is that it didn't look at the severity of the complication. And Johan Langendijk actually published a paper here that I think is really helpful here. And what Cohen's d is basically a statistical measure of what we call clinical significance here. And what you can see is S is for small, M is for medium, L is for large. And this is by the grade of toxicity, and this is for RTOG swallowing. So grade 3 and 4 is basically PEG dependence here. What you can see is for these various domains, if you actually have PEG-dependent swallowing complications, the impact on one's quality of life as measured by the EORTC instrument is actually quite large. In other words, severe late complications do matter, and patients actually don't recover from that, or they actually don't feel like their quality of life is back to normal. And it doesn't improve over time. Grade 3 and grade 4 compared to grade 0, even grade 2, there's some suggestion that they kind of get used to, and this may be actually what the Chicago group was actually measuring there. So severe PEG-dependent complications, it really does matter. And then this is just stating the obvious that we all know these HPV-positive patients do well regardless of the treatment modality that we use. Now, what about the quality of life specifically in the HPV-positive patient? And why do I ask that? Because we now know that the demographics of our HPV-positive patients is different. They're higher functioning, a different socioeconomic group, and it stands to reason that if I'm higher functioning and I have to keep working and I enjoy my life because I'm active in doing this, that any side effect, even smaller, lower grades of lower severity of side effects can actually impact on my quality of life. And the only paper that has actually addressed this is actually by Bevan Yu, and who's kindly lent me this slide. It's still unpublished. I looked for it. But what he showed was actually HPV-positive patients actually are more prone to actually greater decreases in the quality of life, and that radiotherapy is a big part of this. And that's the second learning point that we have to think about as we develop new strategies going forward. And this slide here shows basically in gray here the HPV positive patients at baseline, after treatment, and at 1 year. And you can see that they dip and they start to come back, but it doesn't really come back to baseline. The non-significance is really comparing the HPV positive versus HPV negative. This group, the HPV negative, do dip, they do come back, but there's less of a delta in their overall measure of quality of life, and they use the University of Washington score. When you actually looked at the multivariate analysis here, the factors that predicted for quality of life measures was actually, as we would hypothesize, HPV positive disease. Big cancers had a negative impact, as you would also imagine. And what about at the end of treatment? The only factor that fell out was radiotherapy. Right. So what that means is that we have to do better. And the one factor that seems to be related to both PEG dependency and also quality of life, I'm going to show these in the next few slides, is actually the dose of radiotherapy. This is a paper by Peter Levendag here, and the reason why this is valuable is because the dose range on the constrictor muscles, in this range we usually never see with external beam radiotherapy techniques, but they also use brachytherapy, and the purists will say that adding brachytherapy dose with external beam radiotherapy dose may not be accurate. But what it did do is it allowed us to characterize this end of the curve. And these curves, this is for RTOG, grade 3 and grade 4, basically PEG dependency. This is the dose on your superior constrictor muscles, and what you see plotted out here is a suggestion there may actually be a threshold here, somewhere in the high 50 to 60 gray range. They also had the benefit of quality of life measures using the EORTC head and neck instrument, and they also showed that the shape of the curve was very similar as well too, providing further external validation that dose is related to late complications, and it does impact on patients, particularly when it's very severe. It's a very consistent story we're seeing in the literature here. And this is just one of the tables from then. The point of this was just to see the shape of these curves. It increases with dose for all the various instruments that they used here. We also have the benefit of 4 large retrospective reviews that have actually had enough patients, have had enough events to also do multivariate analysis to be able to evaluate what factors are important in terms of predicting for the risk of late PEG dependency. And I've outlined them here, and I've also outlined in red here the factors that actually that overlap, particularly the treatment-related factors. And I want to give you an idea, or sort of peek into some of these papers in terms of the magnitude of the impact. Radiotherapy, at least in the University of Alabama study, had a 9-fold increased risk. Interestingly, even IMRT actually had a suggestion of an increased risk. I think that this was probably because they were still in their early learning phases, and there's a whole issue of learning the anatomy and applying it. In other words, IMRT can hurt as well too. The paper from Europe by Peter Langendijk actually gives some insight into the impact of the volume of the neck that you get irradiated, as you would expect, because unlike in the US, where the traditional approach has been to irradiate both sides of the neck, in Europe there was a greater practice to irradiate only one side of the neck for appropriate indications. And you can see that when there were indications to treat both sides of the neck, the odds ratio was 5 times in terms of the risk of grade 2 to 4 swallowing complications at 6 months. These were primarily sort of the really bad, again, PEG-dependent patients. So what we've learned is that HPV-positive patients do in fact have not only higher function, they have a higher expectation that the treatment will not impact on their quality of life, and that any degree of side effects will actually do so, and that therefore we actually have to be even better in designing future therapeutic interventions to reduce the impact on their quality of life. And how we do this includes looking at the radiotherapy dose, probably looking at the volume of the radiotherapy, and being a little bit more selective in the use of chemotherapy. And so I've summarized these factors here just to refresh your memory here, and I'll refer back to this in a minute. When we started IMRT at Penn, we were also interested in using it for parotid sparing, and I show this slide here to conceptually show what IMRT really is. It's basically beams around the patient that effectively pixelate the open beam of radiation to further allow for conformality, and originally designed to shape around the parotids, and this is my proof that it does work. I've had a number of men who have not shaved during the radiotherapy, and he was getting an oral cavity oropharyngeal radiation, and you can see that he has a full beard on the side here, and this is towards the end of this treatment. And that, to me, is the best proof that I'm actually sparing his parotids. We were also interested in trying to deal with a problem that we were facing at Penn when I arrived there. We were having a lot of patients interrupt on the radiotherapy because of the mucositis. And what I wanted to do, and so I was getting introduced to what Greg was doing with his partial laryngectomies, and I was saying to myself, why can't we do the same with radiotherapy? This was before the information came out from University of Michigan about the constrictor muscle dose in 2007. So if we had the cancer here, why can't we try to manipulate the dose of radiation? And I use this as an arbitrary constraint. So I was trying to vertically split and spare as much of the vertical strip of pharynx as I could without compromising on dose coverage. And part of the reason why we were able to do so was we instituted a quality assurance program that Eli Gladstein was challenging me with. In other words, we were starting IMRT, and we had no idea whether or not we were actually giving the dose of radiation to where we wanted to, because the beams were going around the patient, and there was this general lack of or feeling of lack of assurance that we were actually doing what we were doing. And so I started scoping everybody, largely because when I was at the Princess Margaret, I was introduced to that skill set and influenced by Jonathan Irish and Pat Gillane. And so we started putting the scope in, and what you could see was actually that the patterns of mucositis started matching up with the dosimetry. And this is, for instance, to help interpret this, this is the right, this is the left. This is the suprahyoid epiglottis here. This is the piriform sinus on this side here on the left. That should not be as much irradiated. And what you can see flipped around is that the right piriform sinus, area epiglottic fold, suprahyoid epiglottis has a lot of mucositis, and on the left there's nothing there. So we were consistently seeing that we could actually deliver the dose on one side more than the other. And this is just an enlargement to show you that. And we went back and we looked. Ari Dosimetric was a medical student. Unfortunately, here another pointer. What we demonstrated was we went back and we looked at the PEG dependency rate, and it was 6.7%. But when we actually broke it down by chemoradiation, we saw that we were high. We were in that ballpark range of about 9–10%, which is what everyone else was reporting in the literature here, sort of that 9+%. But interestingly, when we actually looked at the cohort of 20+ patients with TORs, because this was sort of a sort of, Greg and Bert started TORs back in 2005, 2006, while we were still concurrently giving radiation definitively in some patients. And so there, thank you very much. And so what happened was is that we had the ability to observe the fact that none of these patients were PEG dependent. They had a minimum of 2-year follow-up. And so part of the reason is that I had to make a critical decision when we were irradiating them in the post-op period. It would seem like a dull thought process, as my teenage son would say to me, but it wasn't as obvious at that time. And what I mean is that when we were treating these patients in the post-op period, oftentimes there was a practice that what you did was you had to treat a large volume, drawing back on the historical slides that I showed earlier on, because there was a general belief that you had to treat a big area, particularly after surgery. And transoral surgery kind of refutes all that, because you're not cutting a lot of tissues. You're not placing them at risk for seeding. And so we made a decision to actually only treat the invasive base. And what that allowed us to do was significantly reduce the volume that we ended up irradiating. And we it also helped to deal with this issue here, that we no longer had a mass that extended into the lumen, what I call juxtaposed to tissues that are involved with swelling but were otherwise not involved with cancer. And this is what I mean, for instance. This is a patient that I examined in the clinic. Greg, this was really illustrative of this principle, and I think this is actually in Greg's textbook now. And what this actually shows is that this is the dorsum of the tongue. This is the anterior pillar. This is the posterior pillar. This is the base of the mass. This is actually the pedunculated lesion here that actually, unfortunately, falls back into the main laryngopharynx as you're looking from the nasopharynx, is actually sitting on top of it, your epiglottis and your aryepiglottic fold. And with manipulation in the clinic, I could actually get my scope underneath here and show that it was not invading on the epiglottis, nor the aryepiglottic fold, nor the piriform sinus. It was just sitting on that. The real invasive base was in the glossotonsillar sulcus, a little bit in the lateral vallecula, and as I said, in the tonsillar fossa. And if I was to irradiate this patient definitively, which was the standard, it was T3N0 with chemoradiation, I would also exacerbate the problem, because what we do is technically place the patient in what we call the supine hyperneck extended position for a number of technical reasons. And this is an examination with the patient in the upright position. You can imagine that if I put this patient in the treatment position, I could compromise the airway, and I would definitely unnecessarily irradiate, in essence, almost all of the pharyngeal constrictors back here, and in essence, all of the endolaryngeal mucosa, including the arytenoid cartilage, and cause unnecessary toxicity. And so the idea here is that you had an oncologic procedure that removed the tumor mass that otherwise, if it was to treat non-surgically, I would have little ability to spare the strip of the pharynx. And actually, the radiation would expose a fair bit of the circumference of the pharynx to unnecessary radiation as well, too. But in the post-TOR situation, after an oncologic procedure that sought to achieve negative margins, what I was left with was this invasive base, and that when I plan, I could do something like this and spare a lot more of the pharynx here. And in fact, actually, because we had initiated a process of whereby we were also evaluating patients by scoping them on treatment, we were able to make consistent observations that this was the case. And you can see here, this happens, the battery must be dying. This is a patient with a tonsil cancer post-transoral resection. This is the granulated bed with mucositis on the right side. Coming to midline uvula, you can see that the mucositis is right to here, comes to midline, and then the left side, there's no mucositis at all. And this is a blow up here towards the end of the treatment showing this area here. We can achieve greater sparing of the pharynx after transoral surgery for specific lesions. Remember, I don't believe that is a panacea for everything I'm going to show, but certainly for lateralized tonsil and lateralized tongue-based lesions, we can achieve this kind of dosimetric sparing by combining modern conformal radiation with transoral surgery. And the long-term follow-up, patients do really well. This is a patient who had post-op radiation. You can see the post-op changes here on the right tonsil fossa, glossotonsillar sulcus. You see the tissues are well preserved. And in this patient here, even when he shows some fibrosis and telangiectation, I think that there are some patient-related factors that also add to late complications. This patient I just recently saw in follow-up who came to Hopkins to see me, in 2 years follow-up, you can see beautifully that the radiation that came right to here, and the epiglottis does not show any telangiectasia. That's how precise one can be after TORs. And the kind of doses that we get to the constrictor muscles are now more in the 4,000 range. This slide also highlights one other issue that we had to start thinking about, in that I think we have to start thinking about oropharynx cancers by dividing them into lateralized lesions versus central lesions. Because I think the lateral lesions are at less risk for swallowing problems. And we're trying to generate the data both at Penn and also at Hopkins to prove this. But intuitively, I think that that's rational. And then going forward, we have to think about this a little bit. Why? Because the central lesions, I think, are, when you have a tumor mass in here, when you radiate coplanar around here, you're more likely to put those circumferentially around the constrictor muscles. And more importantly, inferiorly, in the floor mouth musculature, this group of muscles that are involved in the laryngeal elevation, coordination of swallowing has not received a lot of attention. And this slide, I don't really need to explain to this audience, but it increases the risk potentially of penetration and aspiration. And to date, the best measure that we have is actually either fees, which is unfortunately still somewhat subjective and semi-quantitatively. But what we wanted to ask was whether or not this hypothesis that we have to start thinking about these lesions differently between central versus lateralized lesions is valid. And so we wanted to ask whether or not there was any proof that the dose of radiation could actually be correlated with the risk of poor laryngeal elevation and laryngeal penetration and aspiration. And so what we did was we had a cohort of about 40 plus patients that had come through our multidisciplinary clinic, where our speech pathologist, Heather Starmer, sees them with us. We do a fees at that time, and she also does the fees during, at the end of the treatment as well, too. And so we had this cohort that was prospectively evaluated. We had the dosimetry. We went back and we counted all the individual floor mouth musculature, the hyoglossus, the anterior belly, the mylohyoid, and we also then took it as an aggregate, also the floor mouth. And what we found was that it actually, on logistic regression, that the volume of the floor mouth musculature that received 45 gray does actually correlate. And so this is, to me, further support that we have to start thinking about how we approach oropharynx cancers, particularly HPV positive patients, differently. Because what we're doing is we're placing more critical central muscles that are involved with swallowing at risk. And therefore injuring the swallowing apparatus. The other reason why we have to think about lateral versus central lesions is the risk of contralateral nodal metastases is different. For tonsil, we have a good idea in terms of what the risk of contralateral nodal metastases is for well-lateralized tonsil cancers. This largely comes from the radiation literature. We don't have that for, as Ed and I were chatting on the way here, that risk of contralateral metastases to the opposite side, it would be for, say, a tongue-based lesion. And does it differ for a lateral tongue-based lesion versus midline? And therefore, do we need to put the radiation across to the outside of the neck? Why is that important? Because every time when you put dose of radiation here, you increase the dose of radiation to the constrictor muscles in the volume that gets dosed. Lastly, we also have to ask whether or not the functional deficits with resection, be it transoral robotic or TLM, differ if you're resecting centrally versus laterally. Does that differ in terms of the propulsive force? Does that affect the laryngeal elevation, separate from the obvious regurgitation that you would have in the midline soft palate? Up until now, a lot of the work that has been done has been looking at patient-related factors. This is the only paper that I could find. I think this was from Alabama, I think it was, that showed that age may be an important factor, and we know that pre-op swallowing dysfunction as a result of the tumor also is important. And so at Hopkins, this is the video I wanted to show you. What we've been doing is collaborating with Amy Morano, who's actually an Odo, and she has been taking the technology that was first started in cardiology and being able to use MRI in both the cine mode and what we call tag mode. So imagine actually, if I was to click on the mouse, all these checkers would actually be moving, much like when you're speaking or swallowing. And what it allows us to do is take an MRI and keep track of every voxel that we assign as the muscle of the tongue, for instance, and even on the lip. And we can then evaluate its displacement and the force of its displacement and in which direction, and provide a quantitative measure beyond sort of current semi-quantitative assessments like fees, and be able to give us potentially the statistical power in the tool to evaluate the swallowing impact of radiation, chemoradiation, transoral surgery, whether or not surgery in midline is different than laterally. These are the tools that I think we need going forward. And this is just one example where Emmy was able to take a control. This is a visual projection of the vectors for each of the voxels on the MRI of the tongue as this normal patient was saying S, and you can see that this is what it looks like. And then for a patient who had a hemiglossectomy, this is what it looks like. So we think this has potential to be applied, A, to evaluate swallowing, and then to be applied in patients who have had transoral surgery and or chemoradiation. And so the next set of slides I want to do is I want to show you how the radiotherapy doses are impacted based upon this transoral surgery. And in essence, the summary principle that I want you to take away is that right now, the postoperative doses of radiation that we use right now are likely at or below the threshold of injury of the normal tissues. And the reason why I say this is it's been said by many people who have evaluated transoral surgery and post-op radiation, what is 10 gray going to make, what difference does 10 gray make? And I want to show you what that 10 gray, that difference is for late swallowing complications. This trial I already showed you before was Lester Peters. This helped establish the dose range of 57 gray to 63 gray and basically showed that there was no difference in local control. And so this is the dose range that we're currently using. It does make a difference for those patients who have extracapsular extension that 63 gray is recommended, because if you give 57.6, it's probably suboptimal in terms of neck control. But as I showed you before, the best, Peter Levendag demonstrated that there seems to be a threshold somewhere between 55 and 60 gray. That's in the post-op dose range. In fact, the follow-up MD Anderson trial to the Lester Peters paper that actually asked whether or not accelerated radiation was better in the post-op setting actually did report on late swallowing complications. This was a bit of a gem when I was looking back on this paper. Table 2, actually, they actually followed these patients long enough and reported late toxicity. And lo and behold, dysphagia is actually here. And lo and behold, the group that got 57.6 gray had 4%. And lo and behold, those that got 63 gray were over 10%. These numbers are very consistent observations, independent observations that suggest that if you're giving large volumes of the pharynx, doses 60 gray or more, you start to increase the risk of late fibrosis in these muscles, and therefore late swallowing complications. And so one of the things that is one of the trials that likely will be activated in this coming year that I was fortunate to have a role in, will actually ask whether or not we can take transoral surgery, be it TLM or transoral robotic surgery, and for those patients who do not have high risk factors that justifies the addition of concurrent chemotherapy, that is 2 or more nodes, PNI, we're going to ask a bold question of 50 gray versus 60 gray. I think that that will help really reduce the dose of radiation and will make a big impact in terms of the impact on quality of life and the risk of complications. And the primary endpoint will be local regional control. And it'll be really interesting that in this favorable population, whether or not 50 gray is enough in the post-op setting. If it is, then it kind of really makes post-operative radiation what I call dummy-proof, hopefully. And so this is basically the concept here. This is your neck. You can, for those patients who are randomized to 60 gray, those that involve neck or the primary site will get 60 gray. Otherwise, everyone gets 50 gray. But the central lesions still create a bit of a dilemma. And I want to bring this up again because it's been said that with HPV positive disease, why not just irradiate them? Because they're so radiosensitive. My answer to that is that they may be radiosensitive, but their normal tissues may not be any different. And as I've hopefully convinced you, even if you give 70 gray with chemoradiation, even you make the cancer go away, but you do place them at greater risk. And so Where I see some value with transoral surgery potentially right now as a current de-intensification approach is particularly for this group of patients. We see a lot of these in the oropharynx patients. The lateral lesions, I think, T1, T2 that are N2, after pathologic evaluation, there will be a proportion that will not need chemoradiation, and that proportion is roughly about 30% from studies that we've done at Hopkins and also at Penn, looking at mainly the rate of extracapsular extension as the main indication, because the vast majority of patients will actually have a negative margin. The risk of it being positive is less than 5%. And so what you now have done is taken 30% off the table in terms of concurrent chemotherapy. For the lateral lesions right here, you can have the dosimetric sparing of the radiation across here. The real dilemma is actually the central lesion, because you can't, it starts to then push the radiation oncologists as to whether or not after a negative margin surgery with no adverse primary pathologic risk factors, whether or not you really then extend the radiation field like I've drawn here, or to the middle, include that primary site, even though the pathology is negative. And what is really challenging now is really whether or not Krill and Halsted were right about the need to treat the intervening lymphatics. And because we now have radiation techniques that can do something like this, where we can take that oral voidant structure that I had shown you before, we can make the radiation much lower here. There's still some radiation, but we can make this radiation less than 40 gray and reduce any acute mucositis, and certainly take the risk of late complications off the table. We can irradiate the necks and not necessarily the primary site. For tonsil, it's a bit of, you know, you end up irradiating the primary site with tonsil, because when you treat the neck, you're treating the underlying surgical bed that's really at risk. Where it really starts to come into play is these central lesions in the tongue base. Do I need to extend my radiation out to here electively, even though I have no risk factors here? And I don't have the answers for that. I think right now we have to. And so for the T1 to N2, where the risk of needing concurrent chemoradiation postoperatively, it's probably not the wisest, particularly when there is large bulk disease or there's suggestion of extracapsular extension radiologically. But for the tonsil, the lateralized lesions, where you could potentially get that dosimetric benefit, and even if you had to treat the primary site, to me, I think that is beneficial. And that, plus the fact that then you're only using postoperative doses, that may be very helpful in minimizing the risk. And so here's the other reason why 60 versus 70 gray may make a difference. And this comes from the University of Pittsburgh here. And what they did was they actually retrospectively, and there are some obvious limitations with the nature of the report, but I think the results are illuminating. This is the volume of the constrictor muscles that is getting either 70 gray, this curve here, or 60 gray, this curve here. And this is the proportion of patients, requiring PEG for more than 6 months. What you can see here are two striking differences. One is the shape of the curve and the separation between these patients. When you give large volumes of the pharynx, 70 gray, that 10 gray difference may not make a lot of difference acutely, but long term and in terms of swollen complications, it does make a difference here. And we have to rethink how we approach this. And we have to do so until a trial like what we're doing at Hopkins matures to show us that we can actually drop the dose of radiation definitively. That is in a non-surgical patient. And so Giuseppe Sanguinetti has started this several years ago. At that time, I don't think the whole issue of 63 gray in terms of the risk of swollen complications was the rationale behind it. It was simply because we knew that these patients did better and we had to reduce the dose of radiation. And so we decided to drop it to 63 gray because it was represented roughly a 10% decrease in the dose of radiation. And patients who had more advanced neck disease were actually then prospectively given chemotherapy versus those that did not. Were just treated with radiotherapy. And this is the first trial that I'm aware of that actually basically is testing or evaluating basically what we all think clinically in terms of the value of chemotherapy. And so what we're doing is dropping the dose to 63 gray, and with median follow-up right now of 12 months with 21 patients treated, all PEGs have been removed and there's been no local relapse. There's been one distant metastasis. Baseline swallowing evaluation demonstrated that they were normal to begin. The PAS of 1 to 3 is normal. And post-treatment, 1 to 3 months, the vast majority were normal. There was one patient that actually was abnormal, was having some problems. And so the idea that 63 gray can actually reduce, can be used effectively to decrease and can still have oncologic efficacy is potentially valid here. Because we actually have several patients that are coming on 2 years in follow-up that actually have not had any relapse so far. It's still immature and still too difficult to make any definitive conclusions, but we need more trials like this to be able to evaluate other alternative strategies. And this might be a good strategy for what I call those central tongue-based lesions, where transoral surgery may or may not actually be the right thing to do. The other study that actually may help give us some insight in the next few years is actually ECOG 1308. This was a trial that was started many years ago that gave induction chemotherapy, cisplatin, paclitaxel, and cetuximab for 3 cycles, and then based upon clinical evaluation, made a determination whether or not the primary site got 54 gray or basically 70 gray. The problem with this trial, as much as I like this, is the way it was originally written several years ago. That assessment of response was all endoscopic. It was all on the surface. It did not incorporate radiologic imaging to evaluate for any potential disease at depth. And the reason why I have some reservations is I'm fearful that several years later we're going to see that there were in fact actually more local relapse, and it was not necessary, and that would be a condemnation on this strategy of dropping dose to 54 gray, but more because they did not adequately evaluate those who really had a complete response after chemotherapy. And so we also need more trials like this going forward to be able to evaluate alternative strategies like this. So, and this is basically what conceptually does. Lastly, to the other end of de-intensification is actually not giving any postoperative radiation. And in fact, there's actually some good data to support what I showed you before with the MD Anderson trial. Greg updated this. We basically had recommended postoperative radiation for everybody who had N2 disease or greater, mainly because of the primary site and the potential for intervening lymphatics, and that there was a track record of observing patients with N0, N1 disease already. And so that's what happened here, and there's 31 patients, follow-up of 36 months. And as you can see here, the risk of relapse is very low, and the vast majority of these patients are N0, N1, and it reflects the policy that was in place when I was at Penn. And this is the other support for this. David Grant published a very mature paper of 44 months of mean follow-up. These patients were treated with TLM. You can see that the risk of local control, or rate of local control or rate of relapse is very low as well too. Very comparable. So for the T1, T2, N0, N1 that is treated with transoral surgery, we have the potential to actually minimize toxicity by managing them surgically with a certain level of risk that at least has been well defined and that can enter into the risk-benefit assessment when you talk to patients. Lastly, I want to show you a couple other things to think about in terms of managing these HPV-positive patients, and I'm going to wrap up in the next minute, about how to maintain swallowing in these patients. This is a paper from University of Florida, what they call pharyngosize. And basically, it's proof that actually the swallowing therapy during treatment does make a difference. And what they basically did was, usual care was in fact actually swallow therapy during treatment. They saw a speech therapist, they were given exercises, they were followed for compliance, and then sham was basically nothing, and pharyngosize was sort of super exercise, where they were actually doing a lot more maneuvers. This is a randomized trial. And they use actually, interestingly, MRI as an objective measure of the impact. And they were actually measuring the size of the muscle, and they were looking at the floor musculature. And what you can see here is that there was a statistically significant benefit of the pharyngosize for the genioglossus, hyoglossus, and mylohyoid muscle compared to even routine swallow therapy. And what I've highlighted here is really the change, the decrease in either the length or the thickness of the muscle as measured by MRI. Even with swallow therapy, there was actually some change, but with the pharyngeal size, there was much less. The point is that it is really important during chemoradiation or radiation to get your patient swallowing. It seems obvious, you tell them, but they won't want to. Why? Because of the acute toxicity, because of particular pain. And so one of the things that we did was when I was at Penn, we came across, we started developing alternative pain management strategies because we were using a lot of narcotics, and the narcotics were causing patients a lot of side effects. And I had used gabapentin before, sort of in another life managing pain, and patients started complaining of their early mucositis as a burning sensation. To make a long story short, what we basically started investigating was prophylactic Neurontin. And we found actually it was very beneficial. Patients actually got through, you could see grade 2, grade 3 mucositis, and they actually had no pain. And the amount of narcotics was actually very low. It was a little bit difficult to generate the data when I was at Penn in terms of to show those endpoints for a variety of reasons. But we didn't really know how it worked until a paper came out about 3 years ago in Cell that actually basically suggested that gabapentin was actually affecting a receptor on both the pre- and postsynaptic junction synapse that was involved in what we call excitatory synaptogenesis. In essence, when you actually experience pain, your body is actively making neural connections and actually generating neurons. And so when you have radiation-induced mucositis, you do that. And it's our hypothesis that actually Neurontin prophylactically, and you can give it prophylactically because it is one of the safest drugs with a very safe toxicity profile because it is not hepatically metabolized. And you can actually give it prophylactically, and patients actually get through and they swallow really well. And this is the proof. This is a paper that we will have presented at Astro. And what we did was when I went to Hopkins, there was a database already of a well collection of data that had been treated without Neurontin, and we were able to therefore compare. So there are some obvious limitations with this kind of work. But these p-values are all less than 0.001. What you could see is that when I started prophylaxing all my patients with Neurontin, compared to the cohort that had not, the mean weight loss was statistically different. Even though everybody had prophylactic PEG placed in as part of the institutional policy that I had continued and I believe in, 100% of those patients who did not get prophylactic Neurontin needed the PEG tube. Only about half actually needed the PEG tube when they were had prophylactic Neurontin started at weeks 1 to 2. And all of that, the time to start the use of the PEG was significantly different, about 2 to 3 weeks later. And the time to use any opioids was lower. And the amount of opioids, I didn't have time to add this in, it was also statistically much lower. The typical amount of narcotic use is typically oxycodone, about 15 to 20 milligrams a day. So we have plans to actually move forward with a randomized trial to prove this. From the point of view of prophylactic gabapentin versus placebo, which I think adds to minimizing swallowing complications in these patients because it takes away the pain as the barrier to do your pharyngeal size. Anyways, lastly, the last strategy that we have open at Penn is actually being led by Sarah Pai, and that is this notion that HPV disease is potentially immunogenic because of E6 and E7 expression. And this study is actually using a trigrid percutaneous delivery of E7 after chemoradiation, which is the strategy that elicits the antigen release using cyclophosphamide to decrease the immunoregulatory signals. And so I leave this last thought to this group, and although I may be preaching through the choir, there is still a general reluctance to view transoral surgery as real surgery. And in fact, we have a precedent that shows that the old Halstedian type surgery is not necessary when you are using adjuvant radiation. And I think that head and neck is now following in that step and for selected patients. And I think that, although Greg may not like this, I think TORS may be the head and neck equivalent to lumpectomy. Because what we now need to do is basically figure out how to strategically use radiation and in which patients this strategy should be used. It's not an answer for everything. So I hope I've shown to you that HPV-associated oropharynx cancers do in fact need de-intensification, and they need de-intensification strategies yesterday. And that right now, a upfront surgical approach in select patients does actually offer that benefit because of the pathologic stratification, but also because it has an influence on how postoperative radiation can be much more selective in minimizing toxicity. And going forward, there will be a number of other strategies that incorporate transoral surgery with decreases in dose of radiotherapy, and there are a number of other strategies that are non-surgical that are also asking similar questions that should offer the HPV-positive patient a number of different options, and we can better triage patients accordingly. This last slide is most important. A lot of this work is largely the influence of my colleagues both at Penn and at Hopkins, who have either directly contributed to work or have had significant influence in the thought process in developing ideas and thoughts, and I'm grateful for all of them. Thank you very much.